I'm on the faculty here at Northwestern Health Sciences University, and this is a topic that's near and dear to my heart, both as an educator, as a practitioner whose focus was in women's health, and as an African American woman, and as an advocate for cultural competency. I'm just delighted that we are doing this Saturday morning. The title of our presentation this morning, our panel discussion, is Healthcare Communication, Bridging the Gap. And so I say that to say it is a solutions-directed discussion. It's a time to share our ideas, best practices, and hopefully leave with some new ideas for how to continue to do this work for the benefit of our patients. And so with that said, I'd like to take a minute to introduce our panelists today. And what I will do is give you their name, and then if you will just pick up the mic and tell us a little bit about yourself, and then we'll go on to the next panelist. So Mr. Nicholas Zimmet.
Good morning, everyone. I'm not sure if I actually need this or not.
If you would, that would be good.
My name is Nicholas Zimmet. I'm an alumnus from here. I graduated in 2008, and I've been in private practice since then in a variety of different settings. I've also joined as clinical faculty here, teaching in the acupuncture program. In my private practice, I primarily work with immigrant communities that have been displaced by civil war. So the Somali Civil War and the events following the Vietnam War in Laos have produced a wonderful group of patients that are the primary people that I work with on a daily basis.
Dr. Kathy Kramer.
Hello there. I have a background as a physician in family medicine. I did family medicine for 10 years in St. Peter, Minnesota. Then I worked just in the ER in Owatonna, Minnesota for 11 years. And now I do what medicine we call locum tenens, which means I'm an independent contractor and fill in where I'm needed. I'm currently filling in for the Northfield Hospital and Clinic System at their Lakeville office. And I work there a couple days a week working as a family doctor. I spent the last year taking classes here in the Acupuncture and Traditional Chinese Medicine program and found it very fascinating. I'm taking a break this term now to see, is it realistic for me to continue the program, or do I have to now just say I will refer to people who do traditional Chinese medicine and do it well? I got interested in the program here and in holistic medicine in general. I'm certified in holistic medicine because there are gaps in Western medicine that I would like to fill. I'd like to try and fill those holes.
Dr. Pat Casella-Maddox.
Hi, good morning. I'm here in a couple of different roles. I'm the Associate Provost here at the university, so I'm here as an educator. I'm also a faculty clinician, and I'm an alumnus of the school in both the Doctor of Chiropractic and the Oriental Medicine. When I initially graduated, I actually had my clinic out in the field. I was in the Phillips neighborhood, and we had quite a diverse population that would come to us there. There was actually several providers that all worked together in that particular neighborhood. Since then, I work both here at this campus as an administrator, but also in our clinic that we have on campus. And I've also worked off-site in our other, for the Oriental Medicine program, for example, about 60% of our clinical internships for students are off-site, so they work in several hospitals, transitional care. We work at Salvation Army, we work at Pillsbury House, and so there's quite diverse and different populations across all of those particular sites. My interest from the educator is really to look at ways we can improve both our educational programs and also our patient care for the populations that we deliver to. I'm glad you're all here this morning.
Ms. P. Van Moore.
Yes, hello everyone, good morning. I'm the current director of the Hmong Language Program. The Hmong Language Program at the University of Minnesota, the Asian Languages and Literature departments. And I'm also a current trainer of different interpreters and translators in different languages in general for legal and medical. I also have an extensive background in interpreting and translating myself and doing voiceovers for many different areas in need of language.
Mr. Richard Lorian.
Hi, good morning. I am the director of the Katie Center, which is a Collaborative for the Advancement of Teaching and Interpreting Excellence. We're located at St. Catherine University. As a practitioner, I've been a working ASL English interpreter for 35 years. At the Katie Center has been around for 11 years. We're a National Center of Excellence funded by the U.S. Department of Education, which focuses on creating resources and materials for sign language interpreters to improve their competency, knowledge and competency, and get more people, more sign language interpreters working in the healthcare industries. Because right now we've got a deficit of sign language interpreters out there nationally. We need about 46% more than we currently have, and we have about 15,000 nationally. But we have a severe deficit working in healthcare right now.
Ms. Jen Avalon?
Hi, I've been a nurse for the last 12 years, mostly at Abbott and Northwestern. So I work with a wide variety of translators and people of all different cultures and languages. And it's so important to be able to communicate to people beyond that cultural and language barrier. So that's why I'm here.
Mr. Mikhail Sandberg.
Good morning, my name is Mikhail Sandberg. I was born deaf. I went to the deaf school down in Faribault, Minnesota State Academy for the Deaf. And I'm currently attending college for my auto mechanics degree. And I come here for acupuncture, and so I'm here as a patient. And I want to talk about interpreting services and the experiences that I've had with that, and I hope that the panel discussion is going to go really well.
Well, thank you all very much. I thought I would start as a reminder of the class standards. And those of you who have been in cultural competency work know that the class standards have been out for many, many years. But these are standards put out by the U.S. government about how to best provide culturally competent care. And the ultimate goal is to provide effective, equitable, understandable, and respectful quality care and services that are responsive to diverse cultural health beliefs and practices, preferred languages, health literacy, and other communication needs. So if you keep that as our backdrop, I want to go ahead and just start with my very first question to the panelists. And I just encourage you and invite you to just pick up the mic and answer the question as you seem appropriate, as you feel appropriate. So as you see it, what are the issues? What are the most common difficulties you face as they relate to language and culture?
Some of the things that I see are, from a clinical perspective, are when I'm working in facilities and I have individuals that are speaking different language from me, or maybe can't hear, etc., can't communicate in the same ways. I also have people, it's interesting to me that sometimes what I have is people that are from the country but can't read either, and so even if they know English, spoken English, they can't read, and so they can't fill out forms. So there's a number of ways that I, as a clinician, become impaired as to how I can understand what their health concerns are, which translate into how well can I be able to help them through the treatments that I provide. So for me, the whole communication piece, from being able to hear, be able to speak, have the same language, understand culturally how to interact with them, are some of the primary pieces.
I'd like to segue from that and say that I frequently run into difficulties where a culture I may be working with doesn't have the same mindset about where does disease come from, where does a problem originate, and you can run into real difficulties where your basic assumption of their mindset is completely inaccurate. And the language kind of follows from that sometimes. So I'll give a very specific example. When I work with a lot of Somali patients, no matter how I qualitatively describe a symptom and try to gather information from a patient, whether they're having a dull or radiating or burning or sharp sensation, the same word gets used to translate every single one of them, which is hanu. And I found that I need to learn very specific language so that I can speak in Somali to those patients to try to guide the conversation in ways that they're not used to thinking about a particular problem.
Actually, that's very interesting. I just did a training not too long ago, and we were discussing in the different groups, and the Quran group said, we have so many words to describe dull. When the doctor says dull, which kind of dull are they talking about? So it's very interesting that you have that too, you know. So I think sometimes it goes both ways, and maybe they just summarize, what they feel like you're trying to get at. And then of course in other ethnicities or cultures of people, it is different. Hmong, for example, you might have these miscommunication of, I think our biggest problem is that we have younger interpreters who understand, who are fluent in English, and yet they only understand one type of dal and Hmong. And then you have the older interpreters who understand the 10 types of dal and Hmong, and yet can't really interpret into the correct English terminology.
For me as an interpreter, I come in somewhat as an outsider or have historically come in. And what I've oftentimes noticed is that the system, I appreciate that you opened us up with we're looking at the benefit for the patient. But what I find is oftentimes the system is designed for benefit of the providers. And the default is almost to making it easier for the provider. And the provider sometimes is not, because everybody's so pressured for time, communication requires time. And especially when you're going through interpreted communication, it requires even more so. And then when you have a cultural context, like the example for the deaf community, you need to provide an extraordinary amount of background as to why I have this issue or problem. So it may start in 5th grade, even though I was 30-year-old, because my sister hit me, and so my ear has been ringing ever since, that it doesn't necessarily, it doesn't follow the conciseness and the quick diagnoses that some practitioners sometimes want. And then the other thing that I recognize a lot is that there's a big problem for the deaf community, certainly, is that the providers oftentimes think, well, I understand you, because the person may be using some of their voice if they feel they're confident in being able to express themselves. So I understand you, therefore you automatically understand me. Whereas that's oftentimes not the case. Providers are very difficult to understand, even for the interpreter, and we share the common language. But that's one of the things that I find that's really interesting, because most people assume that American Sign Language is based on English, but it's not. It's based on French Sign Language, which came from French. And so there's all kinds of misconceptions as to what's happening here, and based on faulty information. Nobody's fault, but just the way it is.
I'd like to point out that modern Western medicine is a foreign language compared to English. Every day when I take care of patients, I'm translating medicine into English. And if a person doesn't speak English, there's another layer of translation that has to occur.
Yeah, I agree with everything all of you have said. I think my biggest challenge in the recovery room where I work now, or intensive care where I worked a few years ago, was mostly, I think like you said, making sure the patient is communicating everything they need to me. It may take time for me to get a translator there. They may not, like you said, there's a shortage with translators. Now we have excellent translators when they do come. But the timing, if somebody comes out of surgery and is in excruciating pain, it could be anxiety. I can maybe read your body language in your face, but there could be a number of things they're trying to convey to me. And I'm more focusing on the anxiety question. I'm recognizing anxiety or pain. Then you find out a little later into the conversation, oh gosh, this was going on this whole time. So there is this leg where I may be communicating the questions I want, but they aren't getting back to me some of the things they needed from me. And then that leaves a gap in care, and getting the best quality care, the best pain management to soothe their fears culturally, whatever they have going on. The different cultures have different ways of responding to these things generally, of course. So that's huge, and trying to recognize and understand these cultural differences and respect them. I have a lot of Russian patients, and they just don't want pain medicine, generally speaking. Now, and I watch them suffer, and I can see them grimace, and I will, recommend that we do this, but I'm not going to violate their belief system or whatever. So it's according to their culture to really understand that and to try and learn it, to treat them the best that you can, So
I wanted to add one other piece that I've encountered. When I'm working with people from different cultures, the rules are different for each group. For example, who makes the healthcare decision? It might not be the patient I'm talking to. It might be a group, or it might be an elder, or whatever. And so that's different sometimes from when maybe I'm dealing with, say, a family member, or I'm dealing with other patients that I've had in the past that are from this culture, many generations. And so that sometimes I don't understand going in the door about, so who am I speaking to? I mean, I always have to speak to the family when there's a group, but it really makes a difference as to who's going to make the decision about what we're going to do.
I have to add the other thing that comes up quite a lot, which is that gender differences can be huge, and it's really the responsibility of the provider to learn as much as they can and be culturally competent so that they are making a comfortable and welcoming environment for the patient. That said, though, my patients are overwhelmingly women, and for most of my practice have been overwhelmingly Muslim women. And so you do need to learn not just what a culture says, but also maybe what a religion says. And you have a burden as a provider to be better educated than you thought you needed to be if you're going to give competent care and make someone comfortable.
Thank you. That was a robust discussion. So, based on some of those things that you laid out as challenges, as ways to move forward, what are the causes and consequences? What are the common causes of communication? What are the consequences to the provider? And what would you say are the consequences to the patient? We could start with the consequences to the provider. Let's start there.
I have comments about that. Over the years, most of my experience in interacting with people who don't speak English would be Spanish-speaking people, and the Somali people, and some deaf people. And I have found universally that if I take the time to communicate, and if I'm kind, and if I smile, that things go pretty well. And that makes it a very satisfying interaction for both of us. And I have a lot of fun when I work with people from other cultures. We may not completely understand each other, but kindness seems to be universal. Another thing I found with my wonderful Spanish-speaking Hispanic patients is I've tried over the years to learn a little bit of Spanish and medical Spanish. And if we don't have an interpreter immediately available, I'll start with my maybe 24 words of Spanish. And because I'm willing to put myself out there and make a fool of myself, if you will, then the patient is willing to use their 1,000 words of English that they embarrassed to use before, so that we can start our communication process.
Other comments on consequences to the provider?
As a deaf person, when I go and see a doctor, just making the appointment, I request an interpreter, and I do all of this ahead of time. And often the miscommunication happens because I think that we're having a live interpreter on site, and I get there and they want to provide video remote interpreting technology to me, which is using a television screen, sort of like the language lamp but then video. but then I have to make all sorts of accommodations in order for the doctor to understand what I'm saying so I can understand what's going on. And that ends up compromising the amount of time that we have. And then I think about things later like, oh, I wish I had said this, but I didn't have enough time, and so I wasn't able to express myself fully because of the limitations of technology and the time crunch.
Consequences to both the provider and the patient there. Please go ahead.
And I have a question for you. As a provider, sometimes there's no interpreter at all, and we end up writing notes back and forth. And I don't know how much that distresses you.
Well, I would say it's an individual thing. If a deaf person is very skilled at reading and writing English, which is their second language, then that might be fine. But not all deaf people are, because it is a second language. So whenever possible, have a live interpreter, because that's going to reduce the amount of misunderstandings and the consequences that affect both the doctor and the patient over time.
I wanted to add a piece to how it affects me as a provider. Over the years, I've had patients that I've known for years, and they've come to me for a long time and refer people in. And I really want to help my patients. And so when there's barriers there, which we've talked about, many of them here already on the panel, I sometimes walk away from an individual visit going, oh, I wish I could have done a little more. I wish I could have known a little bit more. Maybe time just wasn't, there available for us any further. And so I think for a lot of providers, we really care about the people we treat. And we leave that office and we take that with us about what couldn't be accomplished. And sometimes looking for resources to help us do it better next time are sometimes limited, or we don't know where they are. And so that, for me personally, as a provider, would be helpful.
Just with my background in interpreting as well, I think what's really key is to establish who the key people are in the room. And I know that we had mentioned a little bit about that, before, about perhaps there's a whole group of families or whatnot. But I think it's very important to establish that it's the patient and the provider that are the key people. And as an interpreter, I've had to, on many occasions, not look at the doctor at all so that they would stop looking at me and continue to look at the patient, because then it turns into a situation where I feel like myself and the doctor are helping the patient, and I don't want to be involved in trying to help the patient. I just want to be that voice of equal access. And so it's very key for the provider as well, because the patients come in thinking, I'm thinking that you, the provider, and you, the interpreter, are the know-it-all people, and I'm just going to, see how much help I can get from you both. And so for the interpreters to know their training is to be that voice of equal access, and then for the providers to understand that it's very key for them to continue looking at and focusing their attention on the patient while hearing this voice of equal access.
Interpreters have actually taught me that over the years. So if I'm going to make Nicholas my interpreter, and the patient's going to be here, so the interpreter is actually going to be off my shoulder, so that the patient and I are looking at each other, and when the patient's looking at the interpreter, they're still facing me. If the interpreter's over here, the patient will naturally look at the interpreter, and I miss part of the communication. So this is a good spot for the interpreter.
Yes, I totally agree too, because all of a sudden the patient becomes this invisible person. If you are just talking to the translator, you and the translator develop a rapport, and you and the patient don't. Well, that's incorrect. Healing comes with a connection and a communication, so it's absolutely right spot on. That's a big barrier, is just letting them feel comfortable and that they trust you and that you care and that you're making eye contact and reaching out like that. Not just, you do reach out to your translator too and you're appreciative, but it's about the patient and the eye contact in most cultures. So.
All right, we'll go on to our next question then. And we started to talk about that just a little bit, about bridging the gap. And we heard one solution right there to sort of a common cause of miscommunication in the office. some more examples from the providers. What is the provider's responsibility, and what other examples have worked in your environment?
So separate from obviously just trying to educate myself, I've made sure that I hire staff that represents the demographics of the patients, that they can help correct me when I'm making a cultural blunder and I'm completely ignorant of it. And so that in the absence of interpreting, we can still have a full conversation in my waiting room casually or anywhere else. So hiring Oromo, Somali, Swahili, and Spanish-speaking people has been a really big boon for my practice.
Others?
I think the interpreters play a huge role in the healing for the patient, because they have to be really efficient at understanding everything that the patient's trying to convey, and because there's so many different word barriers, like you said, there's only so many words to describe so many things per, in different languages. So that interpreter is just a huge part in the recovery room for me. It's I need them there to a degree. I mean, I can still take care of the patient if the interpreter's not there, but and I really have to use just your human skills when you don't have an interpreter there. Like, okay, what am I seeing? What is there's universal things that you're going to see, but that interpreter just connects the whole thing, and it's so important that they are top notch and they are high grade interpreters, that they really care and they understand medical terminology, that they understand how to convey this to the nurse, doctor, whoever the care person is at the bedside, so that this patient can come out and have a positive experience. They can heal, they can get better, and that's what we all want as the outcome, obviously. And the interpreters, I work with some amazing interpreters at Abbott. It's just whoever comes in there is just outstanding. The care that we can then give the patient, no matter what culture you're from, is amazing because of that interpreter. So.
I wanted to add some examples. A number of years ago, I worked with a doctor who was over in St. Paul, and largely would have a Hmong patient base that would come in. And some of the things that were helpful were to be aware of. What Nick started to talk about was things to be aware of, including about touching and about touching someone of the opposite sex. And we had a receptionist up at the front desk that was from the community, and like Nick mentioned, always gave us tips and things to understand about that. And what I found was that the younger generation that would come in didn't really care so much if they saw me or they saw the male doctor. And those that were older, particularly the men, were particularly sensitive to me working on them and wanting to be with the doctor. And the women liked working with me. They seemed more comfortable to talk about some of the things, maybe with reproductive system, etc., with me. And so it really worked well for us to kind of split that. And there were many patients, and we were able to give good care that way. Sometimes when I've been in the hospitals, one of the things that were perhaps a problem when we had interpretation was that the people that were doing the interpreting maybe came from a different class within that community, and maybe didn't relate to the people that came from a different class. And it wasn't always apparent up front, but later on I found out from the patients or other interpreters, they weren't comfortable in having certain people in because they didn't want to share certain information, or they felt they weren't being understood by the interpreter in their own community. And so I don't know how that is playing out that was much because I'm no longer in some of those hospitals, but that was an interesting twist on the issue of interpretation, helpful or not helpful like that.
One thing I'll mention as an interpreter practitioner, please always, as providers, always feel comfortable asking the interpreter how they are qualified to do this work. Because unfortunately, there was an attempt last year in the legislature to finally get the licensure bill for spoken language interpreters up and out there, and it was, again, tabled. And so there's no defined standard. Now, when you work in a big health facility, they do have kind of a a structure where they're going to vet people appropriately. But there are a lot of agencies hanging shingles and individuals putting themselves out there as qualified. And as we saw, this happens on the international stage, where you saw at Mandela's funeral, an imposter, and now we just had this again a couple of weeks ago. I can't remember where it was, some Spanish in a South American country. There was somebody just flailing their hands, and oh, there's sign language. Well, not quite. I mean, even people who didn't speak that sign language could say that person's just, I don't know what they're doing. So don't be afraid to qualify the individual. Ask for some evidence from them as to why they should be working with you, because it is your practice. You want to make sure that everything's being done well. Also, be willing to share your goal for the interaction with the interpreter, because it certainly helps us in doing our work. If we know where you're trying to go, we may totally restructure how we interpret some of the information, because what comes first or second in English is very different than for the working language I work in, the American Sign Language. I may totally structure what I'm conveying first differently, because it has different weight, different importance, and I'm going to defer to what you see as important, but I need to be the one doing the work in my field, you know. And so any information you can share with us ahead of time. That's why you oftentimes probably you may be bothered by interpreters who want to know what's going to happen. It's partly because we're trying to do our work well. And so any information that you can share will help us. The other thing I will share, it's certainly, I don't think it's unique to the Twin Cities, but it is common in the Twin Cities. And a lot of people are not familiar. It's a situation of the deaf community. 2/3 of all deaf students well, I don't know if it's current this year, but it has been in recent years. 2/3 of all the deaf students in St. Paul Public Schools are of Southeast Asian, New American descent. 2/3 of all the deaf students in Minneapolis Public Schools are East African, New American. So oftentimes you may find that you're not only working with a Somali interpreter, but you're also working with an ASL interpreter, because the family members use both languages as well as English. So it gets very complicated.
So I have to interpret from medicine to English to American Sign Language to Somalian. Holy shmoly.
Just one thing about providers and bridging the gap. What I've learned just over the years in reading information about myself and my culture and my ethnicity, a lot of times there's information floating out there, such as most people do not like you looking in their eyes, or they don't like you touching their heads, or such type of studies. And granted that there are reasons behind these types of studies, but they're made to be they're written in a very stereotypical way. And so as providers, it's very helpful to connect with people as much as possible versus just reading up on information about the group of people, because oftentimes perhaps it's not as it was made out to be. And if you have patients that did not in fact like you touching their heads, I really like what you said earlier about just the human language, the simple asking and your connection with that person, they will definitely allow you to touch their head, and just, for providers with patients such as Hmong families, they come into the appointment thinking that you are the end all and the be all, the solution to all of it already, and so therefore, the way that you communicate with them will open doors.
Another thing that I would say answers the bridging the gap, for me anyway, goes back to what I said about using a few of my Spanish words, where I don't know much sign language, but I know this means thank you, and I know how to introduce myself, that I'm Dr. Kramer. I can introduce myself in Spanish. I can't introduce myself in Somalian, however, I do know the word Hanun. And so when I'm pushing it, I'll say Hanun, Hanun. Little things like that help bridge that gap. If I'm willing to make one tiny step towards where the patient's at, they really take several steps towards me.
Wonderful. Please.
I want to add to that. I totally agree with what you said. And when deaf people make appointments to see the doctor and have interpreting services, anytime the provider can even rudimentary sign to me, I feel welcome. And that's important, to make me feel welcome in that environment. So thanks.
So more on what is now the patient's responsibility. We've talked a little bit about what is the provider's responsibility. How about the patient? What is the patient's responsibility?
So I was thinking when you were saying earlier that it's important to ask an interpreter how they're qualified to be providing the service, that in the communities I have with spoken language interpreting, that there is a deficit of quality interpreting, honestly. And frequently the patient is in a position where they are reliant on the interpreter, not just to translate for them, but to relay anything that's going on, even just what their appointment timing is. And there becomes a dependence that we sometimes see, and I know that going through an agency can sometimes break that, but they want to work one-on-one with someone, and they may have a false conception that if they work with someone who's better qualified, if they work with someone who's going to service them better and not actually create a problem for the healthcare interaction, that there's going to be some kind of reprisal or consequence. And when I've pried far into this, patients have told me, oh, well, the doctor will destroy my record. Oh, if I do this, they won't take me to any new appointments. And I'm shocked when I hear these things. And of course, when you hear something like that, you try to correct the misunderstanding to the best of your ability. But there are challenges where a patient, I think it's their responsibility, is to understand to a degree what is the role of the interpreter and to limit that role to what's appropriate. And it's their responsibility when an interpreter is doing a bad job to fire that interpreter and get qualified help, frankly.
I'm going to just go on with that real quick. Oftentimes, definitely patients don't know that they can fire the interpreter, but we started to have more and more patients that are actually firing their interpreters and say, I never want to use that interpreter ever again, and that's great for them. And then oftentimes, for patients' responsibilities too, if they already speak the language, whether an interpreter was called, it's also very key that they communicate as well, because what I do know, just from the background, just mom specifically, but oftentimes, even though they speak English, they'll just say, oh, it says you're here, just go ahead and do it, and then they'll pretend to not know. And it's very key that your provider knows that you know. So this is definitely a huge responsibility of the patient.
In general, deaf people have a variety of language styles because of the educational system. And so sometimes we get into situations and we have an interpreter who's not meeting our needs. And so it's key for the patient to say, I need a different interpreter and we need to reschedule this, rather than just accepting the situation and trying to go on with it, which could result in misunderstandings or whatever.
I'm reminded of a study that was done in some hospitals in Florida on, there was a women's health study on interpreting in the chiropractic perspective. And the chiropractic perspective, we did a lot with the cervical spine, which for those of you who don't know is the neck. We had patients presenting with cervical spine problems, and the interpreter was interpreting the cervix as a gynecological component. And so you can imagine the patient is presenting with neck pain and wondering why the doctor is now asking them about their female organs. It's just one of those strange circumstances. But, so along those lines then, I guess I would ask the question, what is the responsibility of educators and educating institutions? And what has worked, and what are some examples we have out there?
I want to say one of the things I've been doing is taking notes here. Part of what the university has been doing the last couple of years is defining what our strategies are moving forward. What are the needs of the professions that we actually train our students in? What are the needs for the patient care that we have? And we're revamping both in the academic programs, and we're looking also at the continuing education. And that's where people have gotten licensed and then they go forward, but they have to every year or so many years have a certain amount of upgraded education, different categories. And some of those are in things like professional ethics and safety, working with patients, and all of the topics we're talking about here today really are in that category. And so one of my takeaways today is to go back to add more of these types of topics into our discussion about what do we provide for our practitioners of the future from the programs that we train here for.
I think it's the U.S. Department of Health has an online course in cultural competency in healthcare. As a family doctor, I have to do periodic continuing education in different categories, and I did that course last year, and it was in some ways basic, but in some ways eye-opening. And to just go, it's case vignettes and what's your experience, at least the one that was designed for physicians. So U.S. Department of Health Cultural Competency course. And along that line, my sister is a professor in healthcare communication. She works at the College of St. Benedict and St. John's University. And I invited her to come. She couldn't come. And then she said, what about implicit biases? What about understanding our own implicit biases based on where we come from? And she said she sent me a link from Harvard. They have an implicit association test, so you can actually test yourself to see what are your underlying biases. So if people are interested, it's implicit.harvard.edu/implicit/. And I can write that later if you want.
Here at the school, all employees have to go through annual trainings, and trainings on things like Title IX, training on bloodborne pathogens. Many things are specific to health, others are specific to things like student rights or OSHA laws, etc. And we actually have some of this in our training that we do, and you can choose the different types of categories of implicit bias, and they really are very eye-opening about not only what do you know about their general environment, but where are yours really still exhibited in these particular tasks that they take you through.
Yeah, I agree with that. The implicit bias is the hugest thing I think that can be taught to people. It's hard to teach though, because there's something that lies within yourself that already has been taught. But if you're going to go in the healthcare field, you definitely have to put that down. I mean, even people who speak English, they may be from the ghetto, or they may be out there doing drugs or the trailer park. To put that bias down and to communicate. I've seen people that I work with, not saying I always have a way to smooth things over with people, but I've seen them react in a way where I could see where they're coming from, and they spoke English. Just they thought, they interpreted it as they're just being aggressive and they're being this, but no, they were scared, they had anxiety, they didn't feel like they were being cared for. It's those things like whether you speak a different language or whether you don't, just setting aside your judgment of that and saying, hey, wait, how can I make this better? I mean, I don't mean to bring up walking the picket line, but walking the picket line, I had someone saying F the nurses and all this stuff, and she happened to be a crackhead, you know, but I actually still felt like I should talk to her because she's a human being, and if she wants to express that, hey, that's fine. You don't have to have the same opinion as me. And so we had a conversation. It actually ended okay. Other nurses were like, well, why are you even bothering? Well, I think we should bother with everybody, you know? And so it doesn't matter where. And a lot of the culture experiences I've had, just reaching out. I didn't even have to have the translator there. I could see the anxiety in the lady. She was Somalian, and she wanted out of the recovery room, you know, and I knew, and the nurse was a great nurse who was caring for her, and I happened to be circulating, so I just took over. She wanted tea. She wanted these things, you know, that she wanted. She didn't even realize she had 10 out of 10 pain having a shoulder surgery till she had these certain things met. And I didn't even have to speak her language. I didn't need the interpreter. I just, I could understand a few things to make her comfortable enough. So, and just not be discriminated against her because I don't, because I'm not this or I'm not from that culture, just putting it all aside and leaving all that at the door, whatever, everyone has some kind of bias, but that's what you have to do and is expected and demanded of you as you swear a Hippocratic oath as a physician or as a nurse that you swear to do no harm. Part of that is psychologically, you do have to have people feel trusted or they aren't ever going to want to come and get care. And in order for their body to start healing, as we know at this school here, it's going to take mental, physical, emotional, and the Western, Eastern mix. It's going to take all of that to heal, but more importantly, trust, interaction, that relationship, even if it's eye contact, even if we never speak the same language, even if the translator never shows up, we'll figure it out. And you find a way to figure that out with people. And that's real healing.
Wouldn't you want to be her patient? That's just wonderful. As human beings, we are so quick to be judgmental, and unfortunately, we take healthcare practitioners from the human race. And so they are judgmental.
Yes.
And over and over again, and it just drives me batty. There's this, working in the ER, and we say, oh my gosh, all the smaller people, when they come in, their pain is 10 out of 10, no matter what, it's always 10 out of 10. Well, we have this system of scoring pain between 0 and 10. I actually never looked into it to find out why do all scoring come in 10 out of 10. I had made an assumption, and that is, you don't go to the ER unless you got bad pain. Yeah. And if you got pain, it's bad pain. But maybe that's not even correct. But if you approach the Somali patient with Minnesota American English speaking attitude that not all pain can be 10 out of 10, how can your pain be 10 out of 10? Sometimes it's not 10 out of 10. You totally miss the boat. Yeah. The person is here because they're in pain. And to borrow the crackhead's word, it doesn't actually matter. Take care of the patient.
I want to add a couple of pieces and examples, but I think that the idea of humor and set your bias aside is so important. When I first started teaching at this school, and I was teaching students, and talking about what can the education of student in the university do. When I'm working with them, or many faculties working with our students going these healthcare fields, I want them to question what we're talking about. I want them to bring their perspectives in. And an early situation was I was teaching, and I was in a lab with a group of students, and this one student was really frustrated and wasn't grasping that particular topic that day. And I said, well, you look like you're struggling. What's the matter? She goes, oh, your notes really suck. And my first thing was, what? My notes suck, But I asked her, I said, well, what don't you like about them? And she could very clearly tell me exactly what she needed that was missing. But she helped me help the whole class. And I had recently a patient I'm working with. He has diabetes. He's overweight. He wants to lose weight. He also has diabetic nerve pain and numbness in his legs and in his feet. And so we're talking about diets, and he's not so interested in giving things up in his diet, right? So we're looking for options, and I'll talk about different options, and then he'll look at me, kind of in the eye and challenge me and go, you're trying to make me a vegetarian. And I'm like, no, I'm not trying to make you a vegetarian. I'm talking about the nerve pain in your feet and the numbness, but you have to have that give and take and work with them. Like you said, be a person with them. You can have fun with them and still get, where you need to go. So I just wanted to share those.
part of your question too is asking what the education system can do, and I can tell you what we started doing with our School of Health at St. Catherine. And please, if you want to work on this, I can certainly help you. We started using some of their situated learning opportunities, or where they were working with standardized patients, as they were beginning their clinical practice or getting ready to move into clinical practice while they're still in the classroom. We would bring our interpreting students in, and so it was a double opportunity where the interpreting students had an opportunity to work with the nursing students, or with the PA students, or with the physical therapy students, all the different practices that we have over there. And we could also benefit those programs because we could coordinate patients coming in from the deaf community, and they would give us the standardized scripts, and we would work with those individuals to present in a particular way so that they could go through the structure that they wanted to do. And it's been a double benefit for our program. And we've expanded this now. We have some intense, through my federal program, we've expanded it to Boston University and Northeastern University as part of the Harvard medical system, to Washington State as part of Washington Medical Center, and Michigan, University of Michigan Medical Center. So we've expanded it, and it's had great success in other institutions as well that kind of cross-benefit.
Just mention a little bit more about the implicit bias component, because I think that is so, the word implicit, means that we don't always recognize that we have these biases. And so it's so undergirded, so to speak. And just this idea of when we see a circumstance that isn't adding up within our cultural lens, being willing to say, am I interpreting this differently than it is based on my biases? And what comes to mind for me, again, when you look at some of the studies in the field, is some of the studies from our schools. In the St. Paul schools about 10 years ago, we had some pretty significant challenges where we saw African American kids being overly disciplined, I'm going to put it in those words, by their teachers. And if you're Minnesotanites, when you get upset, what do? Exactly. You kind of calm it down, you just shut it off, and it gets more and more quiet. Well, if you're from some African American communities, the raising of the voice is authenticity. It's saying, hear me, believe me, I need you to hear me. And so you heard teachers with kids who were coming at them kind of loud and big, and teachers saying these kids were being confrontational. And as a result, punishing them even more for that. And you start to see how some of these ways, some of these cultural lenses through which we view our world can really be in conflict. In that case, it was with students, but also the patient-practitioner encounter, the same could occur. So with that said, I'd like to talk a little bit about interpreters then. And maybe you started to talk a little bit about some of the roles interpreters can play beyond just interpreting, and in educating. Are there other things that you could give us by way of tips or from the role of the interpreter? And how do I know what a good interpreter is? What are other things that a good interpreter may know, want me to know, etc.?
I talked a little bit about equal access, being the voice of equal access earlier. As a provider, you can see an interpreter is good is how many questions they ask you, depending on how many questions the patient asks them, right? So if your interpreter continues to answer your patient, or be the go-between person versus the voice of equal access, then you know that there's probably more than just what you're seeing, and that the communication is probably missed. So what you want to observe is an interpreter that asks all the questions that the patient asks. For example, perhaps the provider said something that says something to the interpreter, and then the interpreter interprets it to the patient the interpreter understands the question from the provider, but the information was missed from the interpretation. But when the patient asks, I don't understand what you're saying, and then the interpreter goes, well, what the doctor is trying to say is da da da. So you don't want that to happen. Even though myself as an interpreter, even though I completely understood what the doctor was saying, if the patient asks that, I must then go back and say, I don't understand, what are you trying to ask me, or what are you trying to say? You have to interpret that back. There are, as a provider, you also need to understand that there are some interpreters that do more of, I forget what the term for that is, I'm blanking on the term, but they also do community work where they help the patients a little bit beyond just interpreting. So you might get a little bit different type of interpreters, those who come in specifically just for interpreting, and those who come in and they know that patient very well. It is perhaps the one that comes in with that patient every single time, and sometimes they'll add a little bit more or whatnot, or they'll prompt the patient and they'll say, I think maybe the provider's asking you about such and such, or something like that. So it's very key to, as a provider, to observe the interaction between the patient and the interpreter to see if you actually have an effective interpreter.
That brings up an interesting point, like a lot of us on the provider side will comment on how we ask a question. This is what it feels like. We ask a question, and the patient and the interpreter talk for 5 minutes, and then the interpreter says, no. And to this day, I've never thought of saying to the interpreter, can I please have some of those details? And I should have put them, and it would have helped a lot, instead of me feeling like I think I missed a lot right now.
So I do have a lot of the interpreters in my practice that absolutely work with the same people day by day. They bring them to a lot of different services. They might have a connection, even a familial connection to their patient. And besides the obvious conflicts that I could potentially bring, I think that oftentimes I have interpreters who volunteer information the patient didn't say because they know something about the context. And if this was reversed and I was telling the interpreter something that I know about the patient outside of it, it would be a huge violation of privacy. What am I as a provider supposed to do when an interpreter gives me information that I know the patient didn't say?
This is actually an issue, a big issue that's still evolving in the interpreting field, because we're moving from visitor and communication aid to where we think we should be as a member of the healthcare team. And so the obligations of a party that's a member of the healthcare team to the good outcome, the health outcome of the patient may be very different, and could dictate that the interpreter functions differently. However, then that calls upon the interpreter to have a very different relationship with you than they currently have. So all I can say right now is it's in flux. And that's actually a big discussion within the interpreting field. Where should we, how should we best be doing this work? And you will see interpreters who are employees of Alina, who, for example, have access to Epic, and are charting communication notes for other interpreters who are coming in, so that they know where did the treatment process end, where am I picking up, what's next, and you won't see that with a community interpreter coming in. The other thing too is we have an individual that I see in the room, we have a growing field certainly in Minnesota of community health workers who are bilingual individuals by nature. The best example I have is guardian ad litem in the court system. They're kind of coming in as your advocate, or not advocate, maybe that's the wrong word, but person that understands the Western healthcare system as it's practiced in the United States, regardless of the therapy, the approach that's being used. They know how it works here, and they're working with the patient to navigate through that system. Sometimes they function as an interpreter. In the sign language community, deaf community, we try to keep those roles separate. We have an interpreter, and then we actually have deaf community health workers. Mary Edwards is in the audience right now, who was one of the first deaf individuals certified as a community health worker. And Minnesota is currently the only state that has deaf community health workers, and we have 7, I think. So we're very fortunate, and they have become an extraordinary boost to interpreters because they can go outside of what has been a traditionally narrow function for interpreters. We do not expound on what the doctor has ordered or the therapist has ordered, explaining medicine or treatments or regimens or anything like that, and they can oftentimes go further down that road. So it's becoming a really nice dual role. When it's all contained in one person, that's where you're going to see some real difficulty in knowing when am I stepping over the line and when I'm not. We're fortunate in the deaf community that we've kind of separated those roles, and we're purposely trying not to cross over.
Another thing about interpreters is, if my understanding is correct, when I did my training, interpreters do not have to be translators, and translation is the art of writing interpretations. So a lot of providers don't understand that about interpreters and will say, can you write can you write these directions for my patient? And sometimes that puts the interpreter on the spot. And I've heard horror stories of interpreters writing it, but they don't actually write in that language. So that's one thing. And then another thing I do personally, when I used to interpret more, is I will tell my clients right away, and I'll say, please don't say anything to me that you don't want me to interpret. Because a lot of times they'll say, well, I will take a little, for example, they say, I will take a little marijuana on the side to help me feel better, but don't tell the doctor that. That's just between you and me, And then I'll be like, oh my goodness, now what, right? So there's that piece too. And then also to understand that there are different types of interpreter in different fields. So we have the 2 biggest fields right now are legal interpreters and medical interpreters, and each type of interpreters have different roles. In legal, if they say the private part, we're going to say the private part in long. In medical, if you say the private part, we're going to say the soft spot, because that's the appropriate term. And if they say the actual private part, where the client might feel ashamed or embarrassed, and then they're not going to want to really talk anymore. They might just get through the appointment.
What I would like to do is actually give our panelists about a 5-minute break and give the audience a 5-minute break as well. Let's help ourselves to some more refreshments. And then when we come back, I'd like to spend a little bit more time on interpreters. I'd like to talk a little bit about using family members as interpreters. And I'd like to talk a little bit about just the costs of cultural competency, the costs to the patient, to the provider, to the system. Then I'd like to open it up to some question and answer. So let's get back together at a little bit after 11:15. Thank you.